his anatomy also. Then all the visual disorders, as we all know, that they are described under 12th chapter, that is Drishtigat Rogas, under the broad heading of Timir Kacha and Lingnash complex. And in Shalakya disorders only, Sushut Uttatantra first chapter, it is told that Sankshepataha Kriya Yogo Nidanam Parivarjanam. Yes, Nidana Parivarjan or the prevention is better than cure. It is told for all the diseases, but it is more applicable for, we can say, the ophthalmological disorders, because it is told there only that you consider the eye diseases incurable as soon as it occurs. Means they are difficult to treat, being the Gyanendriya and very sensitive organ, the most important organ. As we all know, the chakshu is said to be the most important among all the 5 sense organs. So Nidana Parivarjan is the very first line of treatment told as far as eye disorders are concerned. And when we try to manage the doshas, any disease, what we have to consider, because retinal disorders, they are not directly described in our text. We have only 12, we can say, Drishtigat Rogas, where the 6 types of Timir, Kacha and Lingnasha, and other 6 type of those Rogas, that is Nakulandhya, Kapha Vidak Drishti, Pitta Vidak Drishti, then Dhumandha or Dhumadarshi, etc. So total 12 disorders are there. And in these 12 disorders only, we can incorporate all the diseases or the conditions which can cause or interfere with the vision. Then how to explain or understand the diseases which are occurring new, means recent, because of the development in the, or the change in the lifestyle, change in the diet, change in the environmental factors, new diseases are coming or their incidence is changing. Like because of the changing lifestyle, now the diabetic retinopathy is more common, which was few decades before not that common. Then ARMD was, once upon a time we used to read that it is found in the developed countries, but now in developing countries also ARMD incidence is increasing. So how to treat these conditions? At first we have to analyze the dosha, then assess the severity and the stage, whether it is in Amavastha or Niramavastha, and accordingly treatment is to be planned, or that is a Samprapti Vikatana. And one can propose or one can plan the line of management. I'll be sharing few clinical experiences. Now coming to the, in a broader way, if we explain the retinal affections or the disorders, there is mostly painless diminution of the vision. Why painless? Because it is in the posterior segment. In the anterior segment, where inflammatory conditions are the mostly causes, there the pain is there. But in most of the retinal conditions, the pain is not there, except the few conditions like optic neuritis, etc., where pain is there. Then there may be concentric constriction of the field of vision, that is scotoma, may be present corresponding to the area of the retina which is affected. There may be metamorphopsia, micropsia, or macropsia. And these terms we find described in the Lakshanas of our Timir Kach Linganash also. Then reduced contrast sensitivity in most patients with a macular pathology is seen. And this is reduced contrast sensitivity we see in the lenticular pathology also, and also in the macular pathology. Now, broadly, the retinal conditions are described, can be described or divided into these categories, that is vascular retinopathies, in which mainly hypertensive retinopathy, diabetic retinopathy, and in pediatric age group, retinopathy of the prematurity is there. In vascular disorders of other disorders of retina like CRVO, BRVO, etc., Coats disease are there. In inflammatory conditions of retina, CMV infection, syphilis, toxoplasmosis, etc. In degenerative conditions, myopic degeneration, ARMD, macular holes, then retinitis pigmentosa are the common conditions. Then detachment of retina. Among the congenital abnormalities, there are many conditions like methylated nerve fibers. If it is not involving the macula, generally they doesn't interfere with the vision because there are developmental defect, and if it will be stationary most of the time, if vision is not affected in the beginning, it won't interfere later also. Hereditary dystrophies of the central retina and the choroid. Stargardt's disease is most common, or the cone and road dystrophy. So these are the conditions among all these classification or the varieties. These are the conditions we see in our Ayurvedic setup, like diabetic retinopathy, hypertensive retinopathy, glaucoma, macular edema, CSR, etc., ARMD, macular hole, CRVO, RP, epiretinal membranes, optic atrophy, RD, road cone dystrophy, Leber's atrophy, etc., which is a hereditary condition. And this is how a person with diabetic retinopathy sees once because of the exudates, hard and soft, macular involvement. If pathology is involving the whole fundus, so this will be the person's vision. Now, in retinal diseases, these are the some of the common symptoms. Like person may perceive flashes of light, sudden appearance of floaters. See, 1 or 2 floaters is not pathological or a serious concern. But if there is a sudden appearance of floaters, big number, bigger size, then it is an emergency. Then the fundus examination is to be done to rule out either lattice degeneration or the other bigger RDA, etc. Changes in the vision, sudden change in the vision, difficult in adjusting to the light changes. So that will be seen RP and the other road and cone dystrophy. Change in the color perception, difficulty in seeing at night, blurring of vision or loss of vision in some areas of the field, like in glaucoma or neurological, excuse me. Excuse me, because I'm having bad throat since few days. So reduced central or peripheral vision, sudden loss of vision. So how to diagnose? Is Amsler grade is a clinical test. Amsler grade is a clinical test to see the clarity of central vision. OCT, fluorescein angiography, ICG, that is indocyanine green angiography. Then fundus autofluorescence, ultrasound, CT and MRI. In some cases, even when we don't find any cause, any organic cause, then the condition is named as idiopathic category. Now coming to the Ayurvedic perspective of retinal disorders. As we all know, in Ayurveda, every organ is said to be Panchabhautik, and in eye especially, different parts are related with the predominance of Mahabhutas. And among all the Panch Mahabhuta, they are in eye, but it is told that Chakshus Tejo Mayam. There is a predominance of Tej Mahabhut and Tasya Vishesha Sleshmato Bhayam. That in pathological condition, there is more involvement of Sleshma or eye is prone for Kapha predominant disorders. And as I told earlier, that we have to understand the drishti. The word drishti is used as an organ, as a process of or the tool of seeing, that is vision. Organ drishti mandala and drishti patala. In drishti patala, that is retina, we can say, which is supported by retina, and drishti mandala, we can say the circular area, the all refractive media, starting from precorneal film, cornea, aqueous humor, lens, vitreous, and then the reaching to the retina. And of course, after retina, through the visual pathway, the sensations reach to the visual center in the brain. So this is all refractive medias we can take as a drishti. Then the drishtigat rogas, as I earlier told, that in by name only 12 disorders are told. 1 or 2 they are more by explained by Vagbhata in Ashant Sangraha and Hridaya, but they are more or less similar. Like they are Dhumadarshi, Aswajadya, then Doshantha. One additional is told by Vagbhata. And in all these drishtigat rogas, there is some structural dearrangement or there may be some functional dearrangement resulting into interference or disturbance in the vision, which can be temporary, which can be permanent. And among the description of drishti, this line I always emphasize how they could describe Khadyot Visphulingabham Iddam Tejobhi Vayavya. That it shines like a glowworm or spark. When we put torchlight, there is a reflection, because when the retina is healthy, then only when the light enters passing through these media, when it is reflected back through the retina, from the retina, then only a person can see. If macula is not functioning properly, and the lights will not be light rays won't be reflected back, then person cannot see. That's why macula should be healthy. And drishti is 1/7 portion of the Krishna Mandala. One, we say that from the external appearance, we can put it as 1/7 of the corneal diameter. One opinion is that it is approximately the area of fovea centralis also comes about to be 1/7 of that corneal diameter. So there are different opinions. All may not agree to this opinion. Then among all the 3 doshas, Alochak Pitta is most important. The Pitta, this Alochak Pitta, 2 components are told. Chakshu Vaisheshik Alochak Pitta and Buddhi Vaisheshik Alochak Pitta, that you all know. Chakshu Vaisheshik Alochak Pitta, we understand like there are rods and cones through which the image is formed, and through the visual tract it reaches to brain center, visual center, and there is a analysis of the image form, there is inversion of the image form, and then that's how the image is perceived. If by trauma, if any damage occurs throughout at any point after the chiasma or before the chiasma in the visual tract, there will be, I can say, impairment of the vision, or the perception of light will not be there. This I have already described. And because of the Panchabhautik composition of the Drishti, all the three doshas are involved in the vision process physiologically as well as pathologically in the vision disorders. Vata helps in the conduction of the rays, Pitta in the perception of the image, and Kapha stability of all the refractive media. So all the three doshas play important part, and all the five Mahabhutas, they help in the composition of the Drishti. Patalas, we all know the correlation and dosha affliction of this each patala, that Prathama Patalgat Lakshanas, Dvitya Patalgat Lakshanas and all, we all know. We'll just see that in the coming slides. And Rasa, Rakta, Mamsa, Med and Asthi. These five dhatus are told in context of four patalas. Majja and Shukra has got role in the brain or the visual center. So all the Panchamahabhut, Tridosh and Saptadhatu are involved in the visual process. Now coming to retina, you see there is, you can say, image generation. So Agni, that is Pitta dosha or the Agni Mahabhuta, and conduction of image occurs through Vayu. So Agni and Vayu Mahabhut as well as doshas, Pitta and Vata. But Pitta and Vata are there, or Pitta Vata predominant disorders are there, but it starts from Kapha Dushti. As we all know, in Ayurveda it is told that Abhishanda is the root cause of all the disorders. Abhishanda is the root cause, means the causative factors which cause Abhishanda or the Abhishanda disease itself is always there to begin with. It starts with Kapha vitiation, and later Pitta and Vata are also vitiated. And if we analyze all the retinal disorders, they are tridoshas in origin. Depending on the predominance of the doshas, they are told as, or they are considered as, Pitta predominant, Vata predominant, or Kapha dominant. And if we see, or as we have seen the classification of retinal disorders, inflammatory and the infective conditions, we can say it is Pitta predominant. And degenerative conditions, there is a Vata dominant. Now, just brief reference, correlating the Patalgat Timir Lakshanas. These are all according to the Patala, first, second and third. Perception of false image such as flies, cobed images, rays, etc. That is Makshika, Mashaka, Jalakani, Marichi, that we see in pathological myopia, or in case of impending retinal detachment. Then distorted details of ear or eyes we see in the macular pathology. Then dosha, according to the arrangement of the doshas or localization of the dosha in particular position in the Drishti Mandala. As you all know, it is told that when the doshas are located in the lower part, patient is, or the person is unable to see the near object. When it is located in the upper part, person is unable to see the distant object, that we compare with the refractive errors. And when person is not able to see all around, or there is a distortion of vision, overlapping of the objects, there is either irregular astigmatism or macular pathology. will be concentrating on retina, so other part I am leaving. In Vatic Kacha, distorted images or polyopia is there, which we see in CSR, ARMD, CNVM. In Pittaj Timira, we see that, or in the retinal detachment, Pittaj Kach, traction of retina. According to dosha, these are the lakshanas we can see, like metamorphosia, moving objects, scotomas, smoky vision, sometimes redness, but not constant. Means transitory loss of vision. It can be because of edema. It can be because of vitiation of vata. Like when we see the acute attack of glaucoma, there is a corneal edema. There is a temporary, you can say, blurring of vision. But once that edema comes down, then the person's vision becomes normal. Then similarly, pitta vitiation, rainbow halos, flashes of light. In kapha vitiation, patient is able to see objects as white in color, sometimes shiny white like pearl, etc. These descriptions are given. And again, according to doshas, this is a modern correlation of certain conditions. Like in pitta, we see congenital deficiency of the cones, central vitreous opacity, central nuclear or polar cataract, ARMD, macular edema, because in edema cannot be there without involvement of pitta or kapha. Though there is a vata, because there is increased space, then only edema will be there. That's why I tell these all retinal conditions are tidoshas in origin. They are tidoshas, but depending on their presentation, we have to see which dosha is predominant. Central serous choroidopathy or CSR retinopathy. There we see the multiple pockets of edema. So there is a separation that cannot happen without pitta and vata. Then macular hole, there is other dosha pitta also and vata involvement also. CNVM, then dhumadarshi pitta. In kapha, RP, congenital night blindness, vitamin A deficiency, vata retinal detachment, or the lesions of higher center. Tridosha, myopic chororetinal degeneration, congenital blindness, hereditary dystrophies, diabetic retinopathy, hypertensive retinopathy, etc. And when we know where the patalgat lakshanas are told, Jalhana says that when the doshas are involving only the first patala, prathama patala, it is sadhya. When there is a raga prapti, reaches to third patala, ditya patala, it is krcha sadhya, tritya patala, it is yapya, and chaturth patala is linganash, that is asadhya. Now the general line of treatment. See, in case of abhishanda, purana sarpisha, etc., all the starting from internal use of purana sarpi to nasse, sek, basti, etc., all the line of treatment is explained by Sushruta. That treatment is very much effective in retinal disorders also. As I told that abhishanda is the root cause of all the eye diseases. Excuse me. Similarly, in Vagbhata, it is told that according to dosha, you have to use either snehana, raktamokshan, Virechan, Nasya, Anjan, Murdhavasti, or any of the four types of Murdhatela, that is Shirobhyanga, Shiropichu, Shirolepa, Shirobasti, Basti, and Seka. All these therapies, it is depending on the physician. It is his, you can say judicious, you can say yukti, that in what stage which procedure is to be used. Like, suppose when there is edema, then dhara, takradhara or the shirodhara is to be used, or vidalak is to be used, lepa. So directly onto the eye or through Shira Pradesh or through Virechan or Vamana. So any of the procedures can be used, but that analysis or the selection of the procedure is by the yukti of the physician. So in Sushruta we know 5 Kriya Kalpas are there. These Kriya Kalpas, like Anjan is used in retinal problems. Very good herbomineral preparations particularly. They give very good result in retinal problems, particularly in RP. And similarly, Shodhana. For diabetic retinopathy, etc., Virechan and Nasya are more in practice, and they are very effective also. As we all know, that Virechan is most effective for eliminating the vitiated pitta from the body. Best for pitta, of course, it helps to eliminate or mitigate kapha also, because in Shalakigat disorders or Nitra Rogas particularly, Vamana is contraindicated or should not be done. And when it is done, it should be done very judicially, very carefully. In some of the Vartmagat Rogas, only Vamana is indicated, but retinal problems particularly, Vamana, I say a big no. Basti can be done when we find or when we feel that there is involvement of Vata. But Vamana, no, because we all know that by Vamana procedure, there is increase in the intrathoracic pressure, and through the jugular vein, it will be putting pressure onto the eyes also, and already the retinal vasculature is weak in all these retinal pathologies. So Virechan procedure or Basti is the better choice, or Nasya can be done. So these are the treatment principles. First, Nidan Parivarjan, as I told, Dehe Shodhan, if Vata is predominant, Snehan Virechan followed by Basti. Pitta and Kapha Pradhan conditions, Snehan and Virechan. Local procedure, Shirobhyang, Sek, Pichu, Basti, Talam or Shirolepaha. We have to see Sam and Niram Avastha also, and Shamana Chikitsa. In case of RP, Vata Pradhan, Tridoshar and Rasayan. In edema, Shofar Chikitsa. In macular edema or papilledema condition, if we follow the Shofar Chikitsa Siddhant, we get very good results. I have one case report on papilledema, which was fresh case, and we got very good results that we have published. And impact of that publication is that I'm getting regularly emails regarding treatment of papilledema, because even after giving steroids and all, patients are not getting relief. Then diabetic retinopathy, we have to do Kledhar Chikitsa. We have to do Shothar Chikitsa if macular edema is there. But Pradhan Vyadhi Chikitsa, that is Prameha Chikitsa, is very important. Then Chakshu Visheshak, like local procedures like Pindu Vidala, Kanjan and Tarpan, and Chakshusha Rasayan after that. Now we'll see few examples. Like in diabetes, we all know that after 5 years, so one study is done. That is long-term study, that after 10 years, how much is the incidence of persons suffering from diabetic retinopathy or other complications, that is nephropathy or neuropathy. Any person, as the chronicity increases, the chances of developing diabetic retinopathy increases. It is told that out of 10 persons having diabetes, every third person has the chances of developing diabetic retinopathy. Or some studies say 1 in 10. So it passes to the preclinical stages, and first there can be background diabetic retinopathy. It can pass like macular edema, clinically significant macular edema and vision loss, or from background diabetic retinopathy, it can pass through pre-proliferative stage, proliferative diabetic retinopathy, and then vitreous hemorrhage or retinal detachment and neovascular glaucoma. When we see that how to treat or manage the diabetic retinopathy, the first important thing is the Pradhana Vyadhi Chikitsa. At present, we have only parameter, that is the glycemic control as per modern medicine, but in Ayurveda, in Prameha, more dushyas are told. And now recently they have also accepted that along with carbohydrate metabolism, the lipid metabolism is also very important in patients of diabetes. And we know in Prameha, all the 10 dushyas are told, all the saptadhatu are involved, and 20 types of Prameha are there. And the last, when there is Vata involvement, that is Madhumeha, or what we say, diabetes mellitus. So important is hypertension and the lipid control. They have only these two, where we have that Asya, Swapna, Sukham, Dadhini, etc. Starting from the Ahar, then Vihara, Nidan, Diva, Swap, etc. So all, if we follow this, starting changing the lifestyle, it also has got very good impact on controlling the blood sugar level or Prameha Lakshanas. Yes, diabetic retinopathy, we don't have direct reference, but we have reference of Megha Jyotimira Netra Prakashika. And in Sushu Sharirasthan, Sushu Samhita, Tuvrakadi Anjan, Mukkadi Yoga, etc. are described in treatment of Madhumeha, particularly Madhumeha causing Netra Roga like Timir, etc. In Harit Samhita also, it is told that consuming more of Katu, Lavan, Amla, Tiksh, Ahar, etc. give rise to Timira. So when we try to understand Prameha, there is already Kleda Vriddhi, Dravaguna Vriddhi, Adi Dhatu Kshaya, starting from Rasa Dhatu. Just 1 minute. Kapha Pitta Prakopa, Rakta Vidaha, then Drava Kleda Vriddhi, Amla Vipaka, Kapha and Pitta Prakopa. And what happens? These patients, as they don't have to take, or they are not supposed to take sweet items, they try to compensate that by consuming more of spicy food, more of fried food items. And what happens? That is further achakshusya. For that part, it's okay. For other, this thing, achakshusya, as well as that will be having opposite properties of rasa dhatu. So they will be developing anemia also, HB will be less. So Ushnavirya Guru Snigdha So prameha, further it will aggravate. Then Vegadharan has got role in, you can say, precipitation of diabetic retinopathy, as well as aggravation of all these non-communicable diseases. So many of the prameha nidanas are achakshushya also. Katu amla lavan, then divaswap, etc. So as diabetic retinopathy, as I earlier told, like any other retinal disorder, it is a Sannipata pathology. We know there are different static from ischemia to leakage to hemorrhage. So leakage, exudate, and edema. There is a kapha predominance in that condition. Hemorrhage, definitely pitta and rakta. And in case of retinal, or in the stage of retinal detachment, vata is predominant. So seeing all these changes, we can assess the dosha, and accordingly treatment can be planned. Sanga, yes, occlusion of the vessels, that is the first change. Shiragranthi, after vasospasm, after that there is aneurysm or vasodilatation. Atipravritti is the neovascularization or leakage, and Vimarga Gamana is the retinal hemorrhages. So all these four type of, we can say, samprapti, we find in one disease. When we have all the four changes of pathogenesis, one disease, it itself says that this particular disease is difficult to cure or asadhya. But still, see the beauty, still we can manage, or we can show some improvement in the vision of these patients, and they're very cost effective. Their single injection, anti-VEGF injection, is very costly, and still patient has to get those injections repeatedly, and that does not check the occurrence of, that doesn't prevent the reoccurrence of the retinal hemorrhage. But by following Ayurveda treatment, definitely we can check that. But only thing is, by conducting some studies, by doing the case reports, we have to report, generate the evidence for that. So in case of background diabetic retinopathy or early diabetic retinopathy, there is a kapha-adhikya tridoshakopa. In proliferative diabetic retinopathy, there is pitta and rakta predominance tridoshakopa. And of course, in advanced diabetic retinopathy, though it is tridosha, but there is a predominance of vata. Rakta is definitely there in all the conditions. Earlier I told, there is Agni Mahabhut and Rakta predominance in the retina. Now the macular edema, or secondary to diabetes, the other conditions also where macular edema can occur because of stress, etc., which can be considered or treated on the principles of Shofa. Ekanga Shofa, Urdhvanga Shofa. Sushruta also, Shofa Chikitsa is given in Chikitsa San 23, I think. And in Charak Samhita, Ekadeshya Shotha is given. In dietary factors, Abhakta, Kshar, Amla, Lavan, Tikshna, Ushna, Guru Bhojanam, Dadhi, Madhya, etc. Madhya has got properties opposite to Ojas. So I told, like, starts from the Rasa Dushti, and hemoglobin and all will be less when the person consumes more of Ushna Amla Lavan Pradhan Ahara to compensate the sweet taste which is missing from person's diet. Then Vihara, Swapna Vipare, Veg Nigraha, particularly in Netrog Nidana, like Nidra, Ashru Vega Dharan, etc. is told. Hormonal imbalance, Atimathon or Garbh Sampedna, like if some problem is there, that Shofa can occur, but this is a general, but for the macular edema, of course, it is not that much applicable. Then how to approach? Nidana Parivarjan, yes. If a person is taking more of such diet, we have to analyze the diet of the person, because at first, go patient never says about his dietary habit. They feel that this diet is normal. If we ask कि आप क्या खाते हैं, तो नॉर्मल खाना खाते हैं, साधारण खाना खाते हैं, but you ask specific food item, then you will come to know, yes, this particular food item or this food habit is causing problem to this patient. So Nidan Parivarjan, that's all you can do, but by taking the specific history. Then in curative, acute and chronic, depending on the stage, we whether it is of recent origin or chronic, then accordingly treatment is to be planned. In CSR, Vata Kaphaj or acute. In chronic, Pitta and Raktaj, because there will be vascular occlusions, neovascularizations, etc. in chronic stage. In acute, when there is a Kapha Pradhana Vatanubandha, there is no involvement of Pitta and Rakta. In that stage, Shirogatam Shirsha Virechane, that is Nasya Adho Virechane Virechan Urdhva Haste Ath Urdhvam. Means there is a, in general Shofa Chikitsa Vamana can be done, but not in Ekadeshya Shof in the Urdhva Chatru. So Vaman is not to be done, that is questionable. Talam, like putting Shiropichu or Shirolepaha, that medicine paste is kept over the bregma point for a few hours. Then Basti, as Kapha is involved there. So Ruksh Basti, Vaishwanar, Dhanya, Amla or Amritottar, with Amritottar Kashaya, etc. In chronic stage, Virechan and Shiromokshan. Again and again is to miss, that is to be repeated. And in this, most safe is by doing bloodletting by leech application. Other procedures which are told in the treatment of Shofa in Susho Chikitsa Stan 23, that is Yatha dosha man vamana virechana sthapanani tikshnani ajasram upsevet sneha swed upnahascha shirabhi abhikshanam shonitam avsechaye अन्यत्र उपद्रव shofa iti shofaditi. So Raktamokshan, Snehan, Swedan, etc. So you Snehan and Swedan, Upanaha, you can do Vidalak, but not Upnaha directly onto the eye. So this Dikshan Gandush, Vidalak, Shiroloip, and Takradhara can be done. And Raktamokshan, if we do, best is to do with leech application. So preventive Nidana Parivarjan, Ahar Vihar, and following the Sadhvrit also. Rasayan, Chakshusha Rasayan. So patient should be advised Chakshusha Ahar Vihar. As we all know, our fast food is not at all Chakshusha. There are a lot of spices are there, vinegar is there, which is achakshusha, wine, earlier the wine means fruit wine or the naturally fermented wines were there. Now alcohol, it is not having the natural fruits, so that is more harmful. But so all these things are to be avoided, particularly a person having any ocular pathology and especially retinal pathology. In curative herbal or herbomineral drugs, Depending on the condition, physician has to select. In Pittaj Prameha, in Pradhan Vyadhi, as we know, is Prameha, and particularly Pitta is to be taken care of. So the treatment told in Pathic Prameha is to be followed. Madhumeha Chikitsa, yes. Madhumeha is the last stage. So you have to take care of all the dosha and doshas, and as earlier told, good glycemic control, blood pressure, and lipid. As we all know, in diabetes, many of the patients' hypertension is the associated condition. There, the retinal condition becomes more difficult to treat if hypertension is associated. Yes, macular edema, told Shofa Chikitsa is to be followed. In Urdhva Raktapith, what treatment is to be given is to be followed in case of diabetic retinopathy. In Vataj, Pittaj, and Raktaj Timir Chikitsa, what is told, that will be helpful in case of diabetic retinopathy. Avishan Chikitsa will be useful. Now I'll be sharing few works. This is a one PhD work done. Effect of Ayurveda treatment protocol in the management of Madhumeh Janne Timira with special reference to diabetic retinopathy. In this, what we did, we made a protocol, holistic protocol, in which first Deepan Pachan was done. And according to the Prakriti of the patient, this either Shivakshar Pachan, Chitrakadi Vati, Am Pachan Vati, or Panchakol Chun or Trikatu with lukewarm water was given for 5 to 7 days. Then Kosha Shodhan was done with Arandvish Taritke, Arand Dashmul Kashai, Drakshadi Kashai, Avipatti Chun, etc. for 3 to 5 days at morning time. Then Shira Shodhan was done by Pippali and Sandhav of Birnasya. There is a reference of Sharangdhar Samhita, or Shadbindu Tel or Anu Tel, Sahacharadi Tel for 7 days. So according to the Prakriti, the suitable drug was given to that patient, and for Prakriti short Prakriti evaluation performa was made depending basing on the Sharangdhar Samhita. Then Marsh Nasya with Durvadi Grit was given for 7 days at morning or evening time depending on the convenience of the patient, followed by Pratimarsh Nasya. Monthly 1 sitting and total 3 sittings were done. Shirodhara by Siddha Taktadhara, Mustai Amlaki Yashti Madhu, Daru Haridra, Lodhra, Masa, Chandan, and Utpal was used for 30 minutes daily for 15 days. At morning time, monthly 1 sitting for total 3 sittings. In oral medicine, Anubhut Rasayan Yoga was given, in which Swarnmakshik Bhasma was also there. 3-gram dose, and it was made into capsule form, so 6 capsules were given for the period of 3 months, and all the treatment was continued along with whatever they are taking anti-hyperglycemic treatment by their physician, either Ayurveda or modern. That treatment was not interfered. So I told Swarnamakshik Bhasma, Vasa, Yashti Madhu, Musta, Guruchi, Haridra, and Trifla. So this is the Rasayan Yoga. This is another work on ARMD done at Jamnagar, in which in control group we had given what the multivitamins the modern persons are using, and in group A, Ayurveda group, Triflagrit, Saptamrit, Loha, Rasayan Chun, that is of Charaka, Guruchi, Gokshu, and Amlaki, and Shatavari, etc. This was MD work. So 12 group patients in group A and 10 in group B. This article is also available online. Now I'll be sharing some of the patients which we did recently at All India Institute of Ayurveda. This is a case of NPDR with macular edema. A 74-year-old female patient, known case of diabetes mellitus, taking oral hypoglycemic drugs since 22 years and hypertension since 10 years, medicine for the hypertension taking since 10 years. She reported to our department in January 2020, complaining of diminished vision in both the eyes for last 1 year. And diminution of vision was more for her left eye than the right eye. And she has undergone cataract surgery in both the eyes before 12 years. There was no family history. Bowel appetite and micturition was normal. Sleep was sound. Afebrile. Okay. Then rest all things were normal. Fundus photography and OCT shows NPTR both eyes and maculopathy left eye. This is the status in January 15, 2020, when she had 6/9 vision in right eye and 6/16 left eye. And after correction, 6/9 and 6/16 left. It started with Pachan with Amritotar Kashai and Chitrakadi Ghanvati. In February, patient got admitted and we did gave oral medicines like Nishamlaki Chun, Guruchi Rasayan, Trifla Chun twice after meal. And external therapies were done, Nasya with Anutel and Shirodhara with Dashmul Kwant and Shirobhyang and Padabhyang with Dashmul Tel once daily. OCT and fundus photos were taken at this time. And patient was comfortable and discharged in March 2020. Then, of course, due to COVID, patient was doing the telephonic consultation and she continued medicine for almost more than 9 months or so, approximately 1 year. And again, she came for follow-up on March 2021 and continued the same medication, that is Nishamlaki, Dashmul Kwant, Gokshadi Gugul was added, Shila Jatwadi Loha was added. Then in November 13, 2021, she again came, again admitted for the second course of treatment. There her vision improved from in the left eye to 6/18. And then after correction, it was 6/12, which was earlier very less, that is 6/36. So after approximately more than 1 year treatment, she got this much improvement. And again, external therapies, we did Shirodhara here in this time. This is a fundus photograph. You can see here, few hemorrhages are there. Here that hemorrhages are there, but less. So in this one eye, more edema is there. Left eye, more edema is there. And then assessment was done on the basis of visual acuity, fundus photography, and OCT. Vision, we have seen that it has improved from 6/18 and then 6/12. This central macular thickness, this is BT, this is AT, reduced from 480 micrometer to 295 micrometer. This is 20th February and this is 16th September 2021. Now, this is a case of RP with CME. in left eye. 44-year male patient. This is a very recent patient reported in the OPD with complaints of diminished vision in the last 1 year. He had difficulty of vision more during the night. Letters cut in between in the left eye, floaters, flashes of light, cloudy appearance in front of the both eyes. According to the patient, he was asymptomatic before 3 years. Then when he started experiencing mild changes in the night vision, but he ignored. And in May 21, he suffered from COVID-19, and then he started experiencing further diminution of vision. Then he approached some allopathy hospital. There he was diagnosed with RP in both eyes. Then he visited another doctor in Ahmedabad, but he didn't get like much, can say, satisfactory relief. So he started symptoms started aggravating. When he came, his vision was counting finger 2 meter in right eye and 6 by 16 left eye. On OCT, cystic spaces was seen in macular region, and the central macular thickness was found to be 408 micrometers, suggestive of cystoid macular edema. It's not moving. I'll just see. So in May 22, the patient came. So right eye vision was 2 meter counting finger, left 6 by 60. Advised to for admission, Pachan started with Nagaradi Kwan, Trikatu Chun and Lavan Bhaskar Chun. Vidalak was done 3rd May to 8th May by Mukkadi Parambada Vidalak. This contains Tripla, Garrick, Chandan, Rakta Chandan, Haridra, Daru Haridra and Lodhra. Actually, this was the drug of one of our PG scholar, and this we did after her thesis was completed. So we had drugs, so we used in this patient. Then Snehepan was done with Mahatriflagrit, Sarvanga, Abhyang and Swedan was done, and Virechan was done with Trifla and Katuki and Gandhar Hastadi and Tel. Madhyama Shuddhi was there with 13 Vegas. There was improvement in the vision in the right eye, 6 by 60 in both eyes. Macular edema reduced on 13th May. Then Takradhara was done, Pindasved and Napunsak Sharbasti was given, which contains Sandhav, Gudu, Chincha, Shatpushpa, Gomutra and Tiltel. Yapan Basti followed by Yapan Basti, that is alternate Anvasan and Niruha Basti was given. Shirodhara and Nichil was also done, and Marsh Nasya was done with Anutel. This is a photograph of that patient having RP and with macular edema. So this was before treatment and this is after treatment. You can see 2nd May and this is 13th May. So in these 10 days only, there was reduction of macular edema. This is another case, RP with full thickness hole. A 36-year male patient came with distorted and foggy vision for last 3 months. For last 6 months, he also had difficulty in playing cricket and judging the ball. There was difficulty in focusing. Visual acuity for distance was 6 by 9 partial in right eye and 6 by 6 in left eye. The fundus photo showed the RP in both eyes and OCT full thickness. Macular hole was there in right eye. Here in November 2021, patient came. Unaided vision was 6/9 and 6/6 in left eye, 6/9 in right eye. OCT was done. Patient was given internal medicine for 15 days, that is Saptamrit Loha, Lagu Malni Vasantras, Mahatriflagrita and Hani, Rasayan, Chun, Brahm Rasayan, and Dashmul Kwat. Mash Nasya was done with Anutel, Padabhyang with Shirbala Tel, and Shirophyang also with Shirbala Tel. Akshi Tarpan was done with Mahatriflagrit. Padabhyang and Shirophyang also was continued. And this 6/9 improved to 6/6, and this was 6/6 only. And OCT started showing in the healing of the macular hole. In December to January, patient again continued with the same medicine. Punanamadi Gugul was added. Nasya was done. Much Nasya with Shirbala till 101 was done. Then Tarpan was repeated. And medicine was continued. This is a fundus picture of RP with macular hole. You can see this is the macular hole. There is a discontinuity. And there is a thickening of the retinal layers. Thickening is still there after second OCT also on 27 December. The first it is on 22nd November. So, but here we can see, though there is thinning, rarefication is there, but that hole is not there. And he has been to his modern hospital physician. Then they have told that patient that now you continue with the Ayurveda treatment as it is showing improvement. So these are the other pictures. Now, this is interesting case that Covishield-induced thrombocytopenic purpura with right central retinal artery occlusion with chronic and acute infarct. This last year, this patient came, 52-year-old male patient with chief complaint of sudden loss of vision in right eye and redness in both the eyes since 7th August. He was diagnosed with Covishield-induced TTP with right central retinal artery occlusion with chronic and acute infarct. Right eye central retinal artery occlusion with ciliaretinal artery sparing. The patient has intraocular TB in left eye 10 years ago and had history of Covishield vaccination, second dose on 27 July. And he got weakness in the left upper limb when he went to vaccination center. Analgesic was prescribed and he was referred to higher center where he was suspected for left post-vaccination brachial plexus injury, and CT brain contrast enhanced MRI and EMG were done. MRI findings are suggestive of hemorrhagic infarct. On 7th August, he developed facial palsy on right side with sudden loss of vision in the right eye. Then he went to AIMS OPD on 18th August and was taking conventional medicine, that is Vicelon. He was prescribed Zincovit tablet ME12 1500 milligram multivite, Magellan 75 mg and Shelcal, and tablet Pentoc, that is antacid. As he came on 7th August to us, after taking the informed consent, we started the treatment. His general condition was fair, but sleep was disturbed. This particular patient was a lawyer by profession. No allergies were there, but history of tobacco chewing was there, non-smoker and non-alcoholic. So when he came, right eye PL/PR negative, PL was there, PR was negative. Left eye, it was 6/12. Only hand movement on pinhole. These are the NCT readings. And thinning of retinal layer was there on OCT. Macular thickness only 15.6 micrometer. Fovea, RNFL thickness, CD erosion not obtained on the first OCT. On this after treatment. On this OCT. Macular thickness was this 309 and RNFL in 93 micrometer, CD ratio 0.5. Fundus examination, clear media, drusense and all, they were there. Visual field could not be done. Here it was 95%. He was given Brahman science, Shilajatwadi Loha, Avipatti Chun, Gluche Adi Kashaya, Arogyavadni, Nisha Amlaki, and Leshun Sir Park was started. Then in September, Patol Katuronyadi Kashaya, Arogyavadni and Chandraprabhavati was given. Patoladikrit Saptamrit Loha, Arogyavadni, Asan Bilwadi Tel Abhyang, Shiropichu and Anutil Pratimarsh Nasya was continued. So Nasya was with Abhijit Tel was done. Then he was undergone Virachan, Snehapan. Classical Virachan was given. Abhyang was done with Karpasasthyadi Tela. Sarvanga Sweda was done with Dashmul Kwat. And Virachan was done with Gandharva Hastadi Arente. Panch Prastritik Basti was given and Takradhara was also done. This is the picture before treatment. You can see the hemorrhage. And this is after treatment. The hemorrhage was absorbed. And though the thinning is there in the right eye, but hemorrhage was absorbed. Thinning is increasing actually, but symptomatically patient is better. This is central serous chorioretinopathy in left eye. This is one patient. 40-year male patient visited our OPD with a complaint of distorted vision in left eye for last 15 days. This was fresh case and we got very good results in this patient. Patient had no history of any systemic illness like diabetes or hypertension, etc. Vision was 6/6 in right eye and 6/18 in left. It reduced to 6/24 with pinhole. Visual acuity for near was N/24 in left eye. OCT we found fluid accumulation in macular region and serous detachment of the neurosensory retina was found. Central macular thickness was found to be 675 micrometer in the left eye. That is on very higher side. On 10th August, can say the patient came first. We gave Shivadi Gutika, depending on starting on the principles of Shofa Chikitsa. I gave Shivadi Gutika, Purnanavadi Kashaya, Chandraprabhavati and Gokshadi Gokul. Marsh Nasya we did for 7 days with Shirvala Tel 101. This medicine continued, and within this 10th August to 24th August, that is 14 days, there was decrease in macular edema of 147 micrometer. You can see this. This is BT and this is AT. And this is the Amsler grid of that patient. This is before treatment and this is after treatment. Now coming to the glaucoma management, we all know that glaucoma is not a single disease. It's a group of symptoms. Like there are out of 3, 2 features should be there. That is raised ocular pressure, then defect in the visual field, perimetry changes and raised intraocular pressure. At least 2 should be there. And the disc changes, fundus changes. That is cupping. So when we approach the glaucoma patients, how we can manage? One is fresh cases. If you are confident enough, there can be, in the very early cases, standalone Ayurveda or modern or other medical system. Combined therapy, the patient is using some drops. We can supplement with our internal medication, so that can be integrated approach. Then, of course, for a person who is prone or who is having family history of glaucoma, but still he has not developed, or there is only ocular hypertension, there is no, can say, nerve damage, that time surgical, like PBI is done or laser PBI is done. So surgical or the parasurgical management or post-surgical medical management. So this way glaucoma patients can be managed. This is data of, this is one study we have done, clinical study on the efficacy of Swan Gari Kadi Gutikanjan alone and along with Rasayan Adi Yoga in the management of Kapha month or primary open angle glaucoma. Actually, there is a lot of controversy. Many people say that we cannot compare glaucoma with Adhimantha, but most of the scholars, they do agree that Kapha month we can put it as primary open angle glaucoma. So in this clinical study, 42 days parallel group comparative trial, 28 eyes were evaluated. This was also PG work. In group A, patients received Gutikanjan, and in group B, patients received Rasayan Adi Yoga along with Swan-Gari Kadi Gutikanjan. And of course, more improvement was found in the second group with the changes in the RNFL thickness and the visual field defect also, though the duration of treatment was less. So in these patients, we need to have data of longer duration. So like this is one patient's report, January 2021, and then this is February 6, 2021. This is January 1, 2021. We can see this, what the dark color is seen, or these continuous points are seen. Here they are gone. So this is early cases, we get better results. In advanced cases, we need to continue the treatment for longer time. So this is overall of effect of therapy in group A and group B. This is group B. In some parameters, these are the subjective criteria like blurring of vision, frequent change in the presbyopic classes, headache, delay, dark adaptation, etc. Distant vision, spherical refraction correction. So we got better result, reduction or the change in the refractive error in the combined group more. This is another recent work completed on diabetic retinopathy. So it's a Jamnagar work, but it was submitted in this 2022. Work was completed. In this also, Mukkadi Yoga was used as Vidalak. Tungdrumadi Tail was used as Nasya. Takradhara was done with Siddha Takra with Musta and Amlaki, and Anubhut Rasayan Yoga was used for internal listing. In this total, 51 patients completed the treatment in each group. The drugs, Tungdrumadi Tail, Takradhara, they all are having reference and Mukkadi Yoga in the Sahasra Yoga. Oral medication, Anubhut Rasayan Yoga was given. And in this also, Swarnamakshik Bhasma and Trifla, etc. are there. And as in the previous study, all the anti-hyperglycemic treatment was continued. We didn't interfere with the modern treatment or Ayurveda treatment for diabetes, whatever patients are taking. In group B, it was kept as control group. They were observed for 90 days and they were assessed at a period of 1 month. And follow-up was, done was for 1 month at 15 days interval. The investigations were done was routine blood investigation, their lipid profile, blood glucose level, serum creatinine and blood urea, and HbA1c and urine examination. So improvement in the vision, subjective, then the visual acuity by charts, ophthalmoscopic finding, fundus photography, and OCT changes. And another important thing is, as earlier told, here also 100% patients were having mostly amla rasa food items. And this amla rasa increases the drava guna or kleda, which is one of the important, you can say, pathological or etiological factor in the pathogenesis of prameha. So this is the findings like hard exudates, venous bleeding, venous dilatation, microaneurysms were there in these percentage of the patients. During follow-up period, no fresh vision related problem as well as other health related issue were reported in any of the patients in both the groups, and no ADR was reported. This is the results. You can see the percentage of relief, mild improvement was seen in A group, and in B, the percentage unchanged was more in B group. Mild improvement in the second group was seen only 25% cases, and as the duration of treatment is less, so for more effect, the duration of treatment need to be more, can say longer. So reduce, as we know, this all are upadrava, diabetic retinopathy or macular edema, etc. So upadrava as such, they are difficult to treat. And if we are getting this much improvement in this such nature of disease, then it is commendable. And definitely these patients, if they start Ayurveda treatment in the very beginning, like a person starts or is diagnosed with diabetes mellitus, then for preventive, he starts taking some Chakshushya Vihar, starts following Chakshushya practices. Sorry. Then sorry, we can prevent the occurrence or delay the occurrence of these complications. This is the quote from Hippocrates: let thy medicine be thy food and thy food be thy medicine. And we know in Ayurveda so many things are told. Ahara is considered as an important causative factor also. And there is an important quote from Lolimbaraj, that is Patya Sati Gadatasya Kim Aushad Nishevane, Patya Sati Gadatasya Kim Aushad Nishevane. So this is Hitahar or Chakshushya Vihar. Matsakshi, Draksha, honey, dadim, shigru, milk, particularly cow milk. Sorry. Sandho, Ghrita, Moong. As we all know, among the grains or the cereals, this moong dal is best. Chakshusha, as it is laghu or easy to digest. Then patol, godhum and raktashali. Among vihar, to protect the eyes from UV rays, chhatradharan, not seeing directly at the sun, padabhyang, using footwear, not looking at the shining object as it is said to be mithya yog for chakshurendriya, atibhasva darshan, etc. So by following chakshusya ahara and vihara, we can prevent the eye diseases or so. Take home message, I would say prevention is better than cure. Yes, but if disease has occurred, the strict control of blood sugar, BP, lipids significantly reduce the long-term risk of vision loss from retinopathy. Then timely intervention at specific phases, it most effective, and you can say it's a cost effective also, because whatever surgical treatment, it is beyond the reach of common man. And yes, Sadhuvrita, Rasayana, Nidana Parivarjana, Dinacharya, if we follow, at, even if you have predilection for the diabetes or madhumeh, you have a history of madhumeh in your family. But if you follow your Dinacharya, Ratricharya, Ritucharya, then definitely a person will not develop early diabetes mellitus or madhumeh. Chakshusya Harvihar adopted early helps more. By analyzing the doshas, treatment can be planned even if we don't know the name of the disease in Ayurveda. So there's a lot of scope by seeing this data, though we cannot document each and every case. And but still, by experience, sharing experience, listening experience from the other practitioners, teachers also, we know that there is a scope for Ayurveda in retinal disorders, but there is lack of awareness among the people about the remedies. And people even don't know that Ayurveda has a specialty in ophthalmology, or they are treating ophthalmic disorders. So we have to educate the general public as well as start or keep on doing the generating evidence so that Ayurveda ophthalmologist reaches to more and more people. So eat healthy, live healthy. That is the message. And finally, thank you all for patience listening.
Thank you, madam, for your very nice presentation in spite of your some bad health.
Yeah, actually it happened suddenly because of journey, so I could not avoid it.
But your presentation is very good, and your take-home message is very clear that लोग जो है वो शाला के तंत्र में इतने काम होते हैं करके शायद नहीं समझते हैं, और तो आपने बहुत अच्छा प्रेजेंटेशन दिया। यहाँ पे सारे वैद्य जुड़े हुए हैं जिन्होंने यहाँ पे आपके लेक्चर सुनने के लिए यहाँ पे वो आए थे। आप सभी का बहुत बहुत धन्यवाद। मैं कोई आपके कोई शंका हो तो आप पूछ सकते हैं। वैसे मुझे लगता नहीं कोई शंका होगी, इतने अच्छे प्रेजेंटेशन आपने दिया है। किसी प्रकार की कोई शंका हो तो आप हैंड रेज कर सकते हैं, कुछ पूछना हो तो आप पूछ सकते हैं मैडम से। वैसे मुझे लगता है आपने पूरे सेशंस में सारी बातें एलैबोरेट कर दी है। बहुत बहुत धन्यवाद आपका. थैंक यू फॉर ज्वाइनिंग द आयुष दर्पण प्लेटफॉर्म. सो डेफिनेटली आपके और भी हम लेक्चर्स का है, जब आप थोड़ा सा और अच्छा फील करें तो फिर हम आपके और भी लेक्चर्स यहाँ पे हम करा सकते हैं. बहुत बहुत धन्यवाद. शायद अत्री जी ने आप मुझे बताया था मैडम के बारे में, तो हम आपका भी धन्यवाद करते हैं, और जो भी यहाँ पे ज्वाइन किया उन सभी का धन्यवाद. थैंक यू मैडम. गुड नाइट.
Thank you.
स्टे
Bye.
सेफ एंड स्टे हेल्दी. थैंक यू.